Hello, everybody. We're moving back in time to episode 200, which was a landmark episode entitled Goal-Directed Therapy in the Pediatric CICU, Follow the Lactate. And in that milestone 200th episode, we spoke once again with Nicklaus Children's Hospital's expert in cardiovascular physiology and postoperative care, Dr. Anthony Rossi. I hope everybody enjoys this trip back in the past, and I know you're going to learn something new, as I always do every single time I listen to Tony talk. I hope you enjoy. Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai. Thank you for joining me for this milestone 200th episode of the podcast. I can't believe it. We made it to 200 episodes. I've had a wonderful time going through so many different areas of cardiology and cardiovascular surgery. I hope you've enjoyed some of this journey with me. Thank you all so very much for listening all the way back from episode 1 up to today, our 200th. I was thinking as I was planning this episode, what should I do that would be special on this 200th episode? And I thought what I would do is bring back one of the most popular guests we've had on the entire podcast series to talk a little bit about cardiovascular physiology, just as he did 4 years ago. Of course, I'm speaking of the great intensive care guru of cardiovascular science, Anthony Rossi, who is professor of pediatrics at Nicklaus Children's Hospital in Miami, Florida. Dr. Rossi joined us for episode 21 back in 2018 when he spoke with us about a paper that he wrote while working at my present institution, Mount Sinai, on the use of mixed venous saturations for the management of postoperative single ventricle patients. That episode has been probably the most downloaded episode in the entire series, and based on the extraordinary popularity of that, as well as my deep admiration for Tony, we're going to review another of his older papers and then speak with him about his thoughts on how to manage the postoperative patient using some of the concepts in the paper. The work we'll be reviewing comes to us from 2005, the journal Intensive Care Medicine, and it's entitled Goal-Directed Medical Therapy and Point-of-Care Testing Improves Outcomes After Congenital Heart Surgery. The first author of that work was Anthony Rossi, and the senior author Redmond Burke. And this work comes to us from the Cardiac Intensive Care Unit in Miami Children's Hospital, now called Nicklaus Children's Hospital. As is usual, when we're done reviewing this paper, we'll sit down and speak with Dr. Rossi about his thoughts on it, and also some general concepts of postoperative management. Some of you may know that I got my start in pediatric cardiology back in 1990 when I was a visiting medical student at Mount Sinai, and Dr. Rossi was the attending in charge of the cardiac ICU, and I think it would be fair to say that he inspired me to become a pediatric cardiologist. And I learned how important it was to have a great mentor in life, as he has been for me, both in medicine and life in general. He's now a very close friend of mine, and I am thrilled that we can have him back this week to share some of his extraordinary knowledge of postoperative cardiac care. Therefore, let's move straight on to this wonderful article from back in 2005, and then we'll have a long conversation with Professor Rossi. This week's article is a wonderful follow-up to our prior episode with Dr. Rossi back in episode 21. And for those of you who may have missed it, I'd recommend you take a listen to better understand the genesis of this week's work, which was published roughly 15 years after the first one we discussed back in 2018. The work we're reviewing is on the important topic of goal-directed medical therapy in the cardiac ICU, which today may seem fairly common, but the notion of protocolizing things and keeping one's eye on the prize, so to speak, was a fairly novel one back in the early 2000s. The authors explain in the start of this work that so-called goal-directed therapy utilizes an algorithm to modify therapy or treatment to achieve a predetermined goal, with variables measured regularly at particular intervals to monitor progress towards that goal. In this case, the authors chose the measurement of blood lactate levels as the goal, and that of keeping the level either low or working towards lowering it. Essential to this protocol was the development at that time of so-called point-of-care testing, whereby a lab test could be achieved very rapidly, usually physically near to the patient, so that the actual turnaround time from testing to result was very small, allowing for the clinician to make decisions rapidly to reduce the length of time in which the goal, in this case lactate, was abnormal. At the time of the paper we're reviewing, there were no prior works using a goal-directed algorithm in concert with point-of-care testing and its impact on critically ill children, and this was what made this work novel and important back when it was published. For those of you who may have listened to our prior podcast with Dr. Rossi back in 2018, you'll not be surprised to learn that blood lactate levels were chosen to be the treatment endpoint or goal of the algorithm, as he explained this to us in that podcast. And they applied this concept to all postoperative patients in the CICU at what is now called Nicklaus Children's Hospital. And the authors state, and I quote, "We assumed the combination of point-of-care testing and goal-directed therapy aimed at normalizing blood lactate levels would increase survival after heart surgery, and so we evaluated the impact of the combination of these changes on the mortality rate in pediatric cardiac surgical patients." This was a retrospective study, and this is important, but the outcomes are quite impressive still. The authors basically looked at all surgical cases in 2 different time periods at Nicklaus Children's Hospital, specifically the time period of June 1995 to June 2001, which the authors refer to as Group A in this work, and then the period from July of 2001 to September of 2003, which they refer to in this work as Group B, which represents the time period when the authors began using point-of-care testing and goal-directed therapy, which again is an algorithm for how to react to the lactate values obtained, which was, again, the goal chosen by the intensivists in this CICU. There were, by the way, over 1,600 patients in Group A and a bit over 700 patients in Group B. There's a table comparing the 2 groups, and basically they were similar, with the exception of a few important differences. The latter group, B, was younger, 185 days versus 327 days, and they had longer bypass and cross-clamp times, with the bypass being roughly 30 minutes longer on average in Group B, and cross-clamp about 20 to 25 minutes longer also in Group B. Newborns represented about 1/3 of the Group B operative cases, whereas newborns were only about 20% of the Group A earlier era patients. Importantly, on average, the RACS-1 scores were similar between the 2 groups. The authors explain that iStat machines were purchased and used in the period of Group B, and they provide their algorithm in Figure 1, which I would strongly recommend all review, as the concepts espoused in this are as true today as then over 15 years ago. The bottom line is that the authors would obtain a lactate level basically hourly for the first 4 to 6 hours in all newborns or neonatal surgeries to keep abreast of oxygen delivery versus consumption, and the authors review how they use the absolute value as well as the direction of change as a rationale for intervening or not intervening, but the goal of all interventions for rising lactate or high lactate values was escalation of medical management, with a general goal of improving systemic oxygen delivery or diminishing oxygen consumption, basically globally improving the ratio of O2 delivery to consumption. How this was achieved would clearly vary based upon the individual physiology, but some of the things that were done included giving blood, escalating inotropes, augmenting afterload reduction, changing the ventilator settings, or other maneuvers, perhaps like sedation or even neuromuscular blockade. And so what were the major findings? Well, let's go on to the results. First and most important, mortality was statistically significantly lower in Group B versus Group A, 1.8% versus 3.7%. The authors did a sub-analysis of the 27 months prior to the Group B period versus the Group B cases and found nearly identical mortality rates, meaning that there was no trend towards this in the immediate period prior to Group B's period. The second important finding was that there was no difference in mortality between Group A and Group B for those patients who were over 1 year of age, but there was a significant difference seen in those less than 1 year of age. Similarly, neonatal mortality was also significantly decreased in Group B, and the authors state that this was not a pattern, specifically reduction in neonatal mortality, that could be seen prior to the period of Group B. The authors then did a small sub-analysis based on RACS grouping, and showed that for lower-risk cases of RACS 1 and 2 grouped together, The mortality was the same in Group A and B, but when combining the higher risk RACs 3 to 6 together, surgical mortality was lower in Group B, where it was 3% versus Group A, where it was 9%. And figures 3 and 4 in this paper very nicely graphically demonstrate the improvement in mortality rates in the neonates and high RAC score cases between Groups A and B patient groups, and the link to the paper will be in the show notes. And so to sort of summarize, in general, after implementation of a lactate normalization goal-directed approach to therapy via an algorithm using a point-of-care device at bedside, the authors demonstrated generally improved outcomes for sicker and younger patients, with less impact on the older, less complex patient groups. In their discussion, the authors review why they embarked on the use of point-of-care testing, explaining that they were looking for the shortest turnaround time in testing to allow for rapid intervention, and they mention their interest in minimizing what they refer to as lac time, by which they mean living with an elevated lactate level. And they also mention that they chose lactate as it had already been established in other scenarios to be a fairly objective measure of oxygen delivery that had already been demonstrated to be fairly good at predicting mortality in the critically ill. They state, and I quote, "We believe that the combination of these changes in clinical practice would result in improved survival for our patients undergoing congenital heart surgery." The investigators speak of how the lactate levels were used to know if escalation in medical management was needed, and restate how these findings demonstrated marked reductions in mortality for patients undergoing congenital heart surgery at Miami Children's during the time period in which this goal-directed therapy with rapid lactates were used routinely and in a consistent manner. They then review some of the literature demonstrating that lactate levels were good at predicting good or bad outcomes in critically ill patients, and how there was even a small prior pediatric work showing that outcomes were worse if the lactate was elevated or rising rapidly. Dr. Rossi and colleagues also review the then growing body of literature on the impact of goal-directed therapy in the ICU on reducing mortality in critically ill patients, but how there was very little in the post-op congenital pediatric patient cohort at the time that this work was written. They reference their own work that we reviewed back in episode 21 on the use of mixed venous oxygen saturations following the Norwood as an example of a positive impact of a goal-directed approach to managing the critically ill child after heart surgery. At the time of this work, point-of-care testing, as was done in this work, was novel, and the authors review how it had been shown to be beneficial in other diseases, such as diabetes management or patients requiring anticoagulation and management of that issue. They then again re-emphasize the fact that an elevated lactate for virtually any form of heart disease almost always indicates a serious physiologic derangement, no matter the form of heart disease, and they state, quote, "A lactate level of 10 always indicates severe physiologic derangement and increased risk for mortality." And they contrast this to the mixed venous oxygen saturation, which, though helpful, can have different absolute values for different physiologies and requires more knowledge on the part of the care provider in interpretation. The authors review the limitations, including its retrospective design, in which they state that most protocols did not change in the two eras other than the goal-directed therapy related to lactate levels, but they admit that there may have been unmeasurable changes, including personnel changes over the time period, as well as a change in the leadership of the CICU at that institution, but they state that they believe these changes to have not been of great importance. And so they conclude, critically ill patients represent a unique challenge to both laboratory and clinical services. Rapidly changing physiologic conditions warrant careful and prompt evaluation and treatment. For patients recovering after congenital heart operations, the combination of point-of-care testing and a goal-directed therapeutic protocol based on serial blood lactate levels was associated with a marked reduction in mortality. The reduction in mortality was greatest in both the youngest patients and those patients undergoing the highest risk procedures. It is possible that goal-directed therapeutic protocols aimed at normalizing other objective indicators of cardiovascular well-being may result in similar improvements in outcomes. Accompanying this work was a brief editorial comment entitled "Goal-Directed Therapy May Improve Outcome in Complex Patients, Depending on the Chosen Treatment Endpoint," and the authors of this editorial comment are Bernard Fry and Duncan McRae of the University of Zurich. The authors of this work start by explaining that though fancy new techniques or therapies are one way of improving outcomes, perhaps the greatest opportunity to improve outcomes comes not from discovering new treatments, but using existing therapies more effectively. They speak of how an emphasis on systems and processes of healthcare delivery and the study of these might have an important and growing impact on outcomes. They speak of how interventions like this can be inexpensive but extremely effective, and for this reason, they argue strongly that healthcare service research that assesses systems of care are vital to improve care. They outline what they believe are the features of a successful goal-directed approach, and they explain that the indicators being used must be inexpensive and safe, and the goal chosen has to be one that is known to be associated with improved outcomes. They explain that to a large degree the work we have reviewed by the team in Miami adheres to these rules, and that they worked to incorporate an algorithm at the bedside for management using lactate as the endpoint, which is easy, safe, and non-invasive, and so meets many of the criteria for what they believe to be an appropriate goal-directed approach. However, they do register some concerns that because of the retrospective study design, it is challenging to know with certainty that the outcomes demonstrated were due to the point-of-care testing and goal-directed therapy. They conclude by stating that, quote, the intensive care community should strongly embrace health services research methods and lobby for funding of research of this type, seeking to achieve a cost-effective balance in the allocation of money to medical research and innovation. Well, once again, we have a very interesting paper from Dr. Rossi that is very much in line with the concepts he explained to us back in 2018 on this podcast. As we have a lengthy interview expected with Dr. Rossi this week, I'm not going to comment now on the work and rather move on to our conversation with Professor Anthony Rossi. Anthony Rossi is the former director of the Pediatric Cardiac Critical Care Unit at Nicklaus Children's Hospital and also the former director of pediatric cardiology at the same institution. Upon finishing his fellowship in electrophysiology at the Children's Hospital of Philadelphia, he first moved to Mount Sinai Hospital in New York City, where he was the first ever director of the Pediatric Cardiac ICU. Following his time at Mount Sinai, establishing this first independent cardiac ICU in New York, he moved on to Miami to become the director of the Pediatric Cardiac Critical Care Unit at what is now called Nicklaus Children's Hospital. Dr. Rossi is one of the acknowledged leaders in the world in postoperative cardiac care and is well known as a talented teacher. And as I have already mentioned on this podcast before, he inspired me to become a cardiologist, as well as many others. And I shall never forget watching him manage junctional ectopic tachycardia in a post-op patient in the cardiac ICU at Mount Sinai in 1990, and how that experience affected me. It is a great pleasure and honor to bring Dr. Rossi back on the show to discuss this topic and to honor us on this 200th milestone episode of the podcast. Welcome back, Tony, to the podcast this week. I'm here now with Tony Rossi. Tony, thank you very much for coming back for our milestone 200th episode. Couldn't have thought of anybody who I'd rather have on. Thank you so much for joining us this week.
Well, thank you, Rob, for having me back. I'm very, very excited to be here. I'm very honored to be the guest on your 200th episode. That is quite an honor, and I'm sure there are dozens and dozens of people who would probably be more suited for this, but I'm happy to give it a go. And again, I'm just very, very thankful and excited to talk about what we're going to talk about.
Well, that's very kind of you to say, Tony. Tony, as usual, very much enjoyed this paper. You should know you're one of the very few people who we've reviewed older papers in, but I thought this paper, like the one we did a few years ago, is so important and interesting that it was absolutely worth reviewing again because people may have missed it the first go-around. Or more importantly, may not have even realized that this is sort of where many of our clinical practices originally came from. So, in 2018, you and I discussed how you and the team at my present institution, Mount Sinai, came to the conclusion that measuring a mixed venous saturation was so important in managing the single ventricle patient, and you showed a remarkable improvement in outcomes in a very short period of time by better understanding and then manipulating oxygen delivery and consumption. At that time during our conversation, you did speak a bit about your evolution towards the use of a lactate level rather than a mixed venous sat, and I thought to start our conversation today, I wonder if you might be able to share with the audience a bit about why over time you moved to the lactate rather than a mixed venous sat, And also maybe share with the audience a bit about what it was like for you at the bedside to get access to a point-of-care iStat machine at that time. And I was wondering if there was any friction you encountered in that time to using that sort of handheld device.
Wow. So it's a great start. And yeah, I mean, a lot has to do with me being recruited based on a lot of the work that I did at Mount Sinai on mixed venous oxygen saturation. Mm-hmm. I had some objective data, and really, without saying it was goal-directed therapy, but our goal was to raise the mixed venous oxygen saturation, which is exactly what goal-directed therapy in shock is. And we had some outstanding results, and that's how I ended up in Miami. I mean, in Miami, they were looking for someone to take over their cardiac ICU. It was started by Anthony Chang, who's an icon in cardiac critical care medicine, but there were some results that weren't as good as they wanted them to be. Mm-hmm. And actually, that data is available online for anybody to look at. We've published all of our outcomes from the day that Redmond Burke started operating here. And you had about a 33% mortality for things like stage 1 palliation over like a 5-year period. And that was about the mortality that they had in Philadelphia, a decade earlier. So, there was room for improvement. We had 2 great surgeons in Redmond Burke and Bob Hannon. And I inherited a great partner in Juan Bolivar, who was trained by Anthony Chang and, was determined and smart and dedicated. And we had some young fellows like Daniel Kahn in the program. But when I got here, I had this approach to managing patients, which was relying on this objective data as opposed to subjective data. And they did their first 3 stage 1s using putting the mixed venous oxygen saturation catheter in. And those patients went home. We figured it out and they went home. It was by that time, the formula was pretty straightforward for managing them once you had that data. And the 4th one came out, he didn't have that mixed venous oxygen saturation catheter in. And I said, what up with this? Robin, come on, what's going on? He said, our kids are doing so well, we don't need that anymore. It's like he just figured, they had gotten so good over a couple of cases that they didn't need it anymore. And it was like, oh, I'm gonna have to figure out something different. And the one thing about the mixed venous saturation, it was the subjective number that, you might not fully understand why it was high or why it was low, but when it was high or low, you knew how well the patient was doing, and you couldn't argue about that. And so now I had lost that. And one of the things I had realized very early in my career at Miami Children's Hospital, was based on my first day visiting. And they had done some complex DORB. And it was post-op day 1, and they did this thing called grand rounds like they had in Boston, where you go around and you see every patient. And this kid was on post-op day 1. They had a senior cardiac ICU fellow who was managing that patient all night. And he was so proud that the patient was, quote unquote, doing well. And he talked about, he has great pulses. And I gave him bicarb like 5 times last night. It's like his blood pressure is good. And I just walked in the room and I looked at the kid and I said, oh, that kid's going to die. And I realized that, at that point in my career, I had well over nearly 500 weeks of service in a cardiac ICU. I mean, wow. The Sinai era was me on every week. Wow. And today, most intensivists aren't going to get that in their lifetime. So I knew that I had an ability to evaluate patients that a junior person didn't. And Anthony Chang before me was all about being the master clinician, and he was trying to make everybody a master clinician. And the problem was that, after a decade of doing this, maybe you reach that point. I mean, not everybody will do it, but maybe you do. But you can't make that happen to somebody in their first year or the second year. And these are the people that are spending all the time at the bedside. So I knew that I needed something. And then it goes back again, to the lactate part. on the point of care part, because those were two things that kind of came together, but were kind of separate. The point of care part was very interesting in that, I never heard of these little point of care iStat devices at all. And I got asked to do a medical mission to Guatemala with a group of physicians from Columbia University. And they needed somebody to set up an ICU, which was literally setting up an ICU in what had been a storage room. So it wasn't a medical room at all. And I said, well, what are we going to do for labs and everything like that? And they said, well, we got this company from Princeton, New Jersey called iStat. And they had this little box, and they had these little cartridges. And it was like one is you couldn't believe that it was true. It was like, oh, this got to be fraudulent, But you run the blood gas and you get it back, and it's like, that seems pretty good. And after using it in Guatemala, I just couldn't imagine that. Like, why would you go back to like a regular lab or a stat lab? But yeah, a total speculation by the entire team. Like we had at Nicklaus or Miami Children's, we had a stat lab right outside of our ICU. And the turnaround time was about 15 minutes during the day for labs. But at nighttime, there was one person, in that lab. They went on breaks. They got overwhelmed with labs sometimes. Turnaround time could be 30 minutes or longer. And it was like, whoa, there's these devices out there that, have a 2-minute turnaround time with almost with 0.2 cc's of blood. And that was about a fifth of the amount of blood that you had to use for blood gas back then. And when you're talking about neonatal surgery and frequent blood gases, that's amazing. And the other thing that it did is it gave, what I noticed is when you gave this device to the nurse, it gave them a feeling like they were participating in the patient's care. And they had a tremendous amount of autonomy. However, the lab, our laboratory for the hospital, was totally against it. Yeah. First, it was we don't believe the data. And it's okay, well, these things were FDA approved, and we proved that the data was, what about the revenues and everything like that? It's hey, this is going to be cheaper, And it turned out that these things were way, way cheaper. And that our labs eventually make a ton of money on this because you pay for the cartridge and they charge for individual tests. But they didn't realize it at the time. So, I finally went to Redmond and I said, look, I got to get this iStat in here with the Lactate. He helped push that through, and it was very, very hard. But the last people I had to convince was the nursing staff. The nursing staff was like, hey, we got too much work to do. You want us to draw labs and then do the lab? It's that's so much more work, and we're too busy taking care of patients. And I said, wait a second. You draw the lab, you fill out all this lab stuff, you have to take it out of the room, you have to bring it, then you have to pull up the lab on your computer. You're going to do this at the bedside, and it's going to be the best thing that you ever had. It'll take less time. They didn't buy it. And we got the hospital to agree to purchase this for our ICU. And then I bought dinner for the nursing staff, the entire nursing staff. And I had a giant meeting with them. And then for someone that likes to, suggest that I'm as honest as I can be, I told the largest fib of my life. And I said, look, I got a deal. In 6 months, if this isn't the best thing you ever had, if this doesn't make your life so much better, we're going to take it out. That's my deal with the hospital. We got a 6 months trial period. That was completely false. Okay. I was so confident that this was so much better from the end user experience, the ability for them to take a small amount of blood and then do a blood gas also gave them autonomy. Hey, if you think someone needs a blood gas, do it first, ask second, and, by the time, 1 month into this, it's they could never go back to the stat lab again. But it was a war at first. And then it's once you did it, you could never take it away. And after we had it, every other ICU in the hospital had to have an iStat.
And Tony, in terms of choosing Lactate as your goal, that was, from reading your paper, it seems like there was a growing literature that in critically ill people, Lactate was a good biomarker for problems with oxygen delivery and consumption. Is that generally how you knew to use that value, or to use it instead of? I understand that you didn't have the central line anymore. Redmond was not giving you that anymore. But is that how you came to use lactate particularly?
Well, it's very, it's again, like, I think two of my best, the things that have made me successful in my career as a cardiac intensivist is that my ability to show up and my ability to pay attention. And it doesn't go much beyond that. Sometimes I can connect the dots after that, but it doesn't go much beyond that. During the time that I was at Mount Sinai, and this is just a great story. It's like, you were taught in the 1980s and early 1990s that if you had a patient who was sick and they were acidotic and they had a base deficit, yes, -5, -7, that they had lactic acidosis.
Right.
And that was it. And in the absence of that, they didn't have lactic acidosis, so all was well. So if your pH was okay and your base deficit was 0, everything is well. And there was this brilliant adult intensivist at Mount Sinai at that time. His name was Tom Iberti. And Tom, he led a group of people who were just obsessed with shock. So there's a guy, an intensivist named Andy Leibowitz and Ernest Benjamin, and those guys were like legendary, but they were legendary in how much they loved what they were doing. And so Tom wrote this paper, and it's a paper that maybe in the adult critical care world gets a lot of credit, but he wrote a paper where he looked at the anion gap, which is basically the base deficit that you got, and lactate. And what he showed was that, when the anion gap is like, -10, the lactate's really high. But there was this whole, section of patients that had anion gaps that were not very, very negative at all, or might be normal. And yet the lactate could be 5 to 10. Now, lactates of 5 to 10, for medical patients are, a lactate of 10 is almost 100% mortality for an adult ICU patient. And a lactate of 5 was like a 75% mortality. And yet, using the anion gap or using the base deficit didn't pick up any of those lactates. So this whole concept that, you could have elevated lactate in the absence of acidosis was totally novel. And then one day, I was, filling out. So back in the old days, you had these like blood gas, kind of papers you would fill out for everyone,
Sure.
Check this, check this, check this. And one day I'm looking at it and it's like, oh, there's lactate on there. And I was just like, and this was probably in the mid to late 1990s. And I was going, did I not ever see this before? Is this something new? And I just checked it.
Okay.
Not knowing what I was going to get, they sent out the book. It came back and I got a number. I had no idea what to do with that number. And for about 3 or 4 years, I was just checking it off, and I was like getting these numbers, and I'm going, this is really curious. I'm not really sure how to use this. Mm-hmm. And then when I got to, when I got to Miami Children's Hospitals, and I realized I could measure this, and now I had the ability to measure that on a point-of-care device, that perhaps aiming my therapy to that instead of mixed venous oxygen saturation would work in a similar fashion. So we developed this kind of, method of managing patients where, if your lactate is elevated, you're going to do something to increase oxygen delivery. Like you're going to, the elevation of lactate that we see in most of the patients in our units is related to, abnormality in the ratio of oxygen that's delivered to the amount of oxygen that's consumed. And it's supposed to be like, we deliver 5 times as much oxygen as we consume. And then when you get to 2 times as much oxygen as you consume, cells develop anaerobic metabolism and your lactate goes up. And that's not the only reason why your lactate can be up, but the majority of it in our patient population, which despite being heterogeneous in the type of diseases that they have,
yes,
it's all about oxygen delivery and oxygen consumption. And I figured if we could target that, then, what it did for me was, one, it took the junior guy. So there were a couple of things. It took the most junior guy, and he no longer had to assess a patient and say, oh, I think that kid's very sick or it's not. He could look at this one number and, it would either confirm what he believed or it would challenge what he was believing at the time. But I thought it gave him the ability to see the patient a little bit more like me. And then what it allowed him to do was, to assess the changes that they made in their management, over a very short period of time. So, in a critically ill baby, you're probably getting a blood gas every hour.
Right.
Well, you can manage you can look at your lactate every hour, and if we're doing something good, it would come down. And, what we did is we encouraged them. We did it's like, look, if the lactate's, above 5, you're going to do something to that kid. I'm not going to tell you what to do because it's about increasing oxygen delivery or decreasing oxygen consumption. You figure it out. Do they need more hemoglobin? Do they need more dopamine? Do they need more milrinone? But you can't sit there and leave them alone. This lactate was a totally objective indice of how well the patient's doing. I like to, honestly, I think of it, as an indicator of cardiovascular well-being.
Yeah.
That simple. When it's low, you're probably pretty good. And when it's high, there's no denying you're in trouble.
Right.
And so, I just kind of morphed over some of it by just being in the right place at the right time with the right people.
Very interesting. Tony, I was wondering if you could speak to the notion of what you describe in the work as lac time, which I assume you mean the period of time when your lactate is elevated, and the ability to reduce the time that the level is elevated. For example, do you think that having a device right at the bedside and having that result in less than 2 minutes was the biggest factor that would account for the improvement that you described in your work then? Or do you think it was just keeping track of it at all, which was the key issue? In other words, do you think it was the protocolized lactate measurement or the fact that you could get those results as quickly, or do you think it was really just both?
Yeah, so lac time is a very interesting concept because when you understand it, it becomes intuitive, but it's not the way that most people, when they're first learning about lactic acidosis, how they think of it, you usually think, oh, the higher it is, the poorer the prognosis. And to a certain extent, that's true. But it turns out that, and it was, so there was another, great critical care investigator from the Netherlands, I think his name was Jan Baker. And he came up with this concept of lac time. And basically, it's the area under the curve that your lactate is elevated. So it's your total accumulation of oxygen debt. If you think of that, you're producing extra lactate, that's oxygen debt. Yeah. And so rather than how high it was in any one moment, how long it remained elevated, was a better predictor of mortality. And so minimizing that lac time became really, really critical. Now, 2 minutes versus, say, if you had a device in your ICU for 5 minutes, I don't know that makes a difference in that clinical decision making. Right. Because if you ask someone to give a blood transfusion, you're not going to get it for 10 or 15 minutes anyway. And it may be like an hour before you see the effects of getting the hemoglobin up. So the point of care devices, I think more were, from a nursing perspective, they became really more involved in the care of the patient. And I think that's really, really critical as opposed to people who were just like, carrying out tasks. They became real clinicians. And it gave them a lot of autonomy. But that's where the lac time came in. And I think it's a great concept. It's how much time you have oxygen debt. And there's a concept in critical care medicine, that, there's only so much oxygen debt you can accumulate. And then after that, you're kind of done. And you end up with end organ damage, and eventually that becomes permanent. So we think of some of these things as like you want to prevent an arrest. And look, everything should be done to prevent, acute events in the ICU. But you're also trying to prevent that patient from being a patient who might spend a week in an ICU and turn them into somebody that spends 3 weeks in the ICU.
Right. No, that's a good point. Tony, as you know, there's a wonderful editorial that accompanied your work, and in the podcast, you haven't heard my description yet, I review it, And although it was very complimentary of your work, they did mention the main concern of this work, and which was, of course, its retrospective design and the fact that factors other than the goal-directed therapy that you described may have accounted for improvements. As someone who was there for the entire time of Period B, I'm wondering if you could offer for us your thoughts on what other factors beyond goal-directed therapy may have accounted for the improvements seen, if any. One of the things that all of us know who know Redmond Burke very well is that, who's the surgeon and senior author of this work, is that he has always, his entire career, been extremely self-critical, assesses his own errors, always looking to improve his outcomes by better understanding how he can improve his outcomes surgically with technique improvements. Do you think that this or other factors may have played a role in these results as well?
Yeah, so that's a great question. And you unfortunately had to bring up that editorial, which was the senior who wrote that editorial is a guy who I respect as much as anyone. His name is Duncan McCrae.
Yes.
Duncan is an anesthesiologist by training, and he was the head of the cardiac ICU at the Royal Brompton Hospital at the time. And, I got to know Duncan through the very first pediatric cardiac ICU meetings that Anthony Chang used to host.
Nice.
And I just thought he was brilliant, and I loved him. And in fact, he could say something critical about something that I did was hard for me to take, but he was spot on because it was like, look, the truth is like a lot of the stuff that you end up publishing, you didn't start out by saying, hey, I got an idea and I want to publish this. It was like, I got an idea and I think our patients would improve if we did something a certain way. It's kind of like a little bit of an experiment, and you weigh the risks and the benefit of it when you're taking it out, but it's a clinical experiment, not at all. I didn't seek out to say, what's the next thing I'm going to publish?
Yes.
It just became very, very clear, in a very short period of time that our results really, really had improved. And we had, one of the things that Redmond doesn't get credit for is his understanding of the value of a database. And so his surgical database is one of the first surgical databases that was, absolutely comprehensive. And cardio access database is his. He developed it here in Miami with Jeff Jacobs. So, I knew exactly what our outcomes were, when I got here. And, one of my first concerns when I looked at the data was, the first thing I think you have to think about is okay, they were 7 years before, and, then this period of a couple of years that I reported on, and were we getting better? In other words, was there a trend, that, I just picked it up at the end and it was like things were heading in the right direction. And so in that paper, you'll see there's I look at I think it's 27 months of the ISTAT period and 27 months before, and there's no evidence that we were heading in the right direction.
Right.
We had the same surgeons, same cath lab. The ICU changed in that my leadership was the difference. And one of the things I joked about, because trust me, every time that I sent that paper to get, try to get it published, some reviewer said, hey, there are other things. And it's like, well, here's the list of things that it could be, and it might just be that I'm brilliant. And I immediately eliminated that one as knowing that can't be true. And the truth is that no matter how smart I could have been, no matter how much influence I could have been, a person is only in the ICU for a short period of time. The leader of the ICU is only in a short period of time. Now I think in that time we may have had only 2 attendings, but that means 50% of the days, I was there, and probably less when you talk about weekends. And at nights, it was far less. So, my finger on the patient, in the bedside may have been, 20% of the time. And then it was 80% of the people that had previously been there. But with a novel way of looking at the patient and assessing them, where I didn't force them to be master clinicians anymore, but I said, look, we're just going to look at this number, and it's not perfect, but all I know is if it's elevated, your patient's not doing well. And, if you can look at the patient that way and aim to make it better and say, look, I think my patient's well, but his lactate is 8, I better do something. Because that's where you fall into trouble. It's like, you get this patient, the lactate's 8, whatever you're doing in a patient isn't really working, but he's not acidotic and his blood pressure's okay. And traditionally, you would kind of not change anything, you know, and if you change something, you'd be afraid that maybe I'll do something and it'll get worse.
Right.
You know, that's always the fear. But once you had the lactate evade, it's like, hey, you were like, you could do almost anything you want to improve oxygen delivery without being criticized because you needed to do something.
Right.
You know, so I looked at a lot of things. Look, Redmond is self-critical. He takes blame for every bad outcome we have in the cardiac ICU and a kid that he operates on, and he's always been that way. But I don't think his way, you know, he came to Miami with that idea that if something's wrong with the patient, it's probably related to what I do, so let's take a look.
Right.
And that's where, you know, we did early postoperative caths with Evan Zahner. I mean, in that era, we had Evan Zahner as the head of our cath lab, and there was nobody more aggressive, and nobody wanted to take a kid to the cath lab more than that. That preceded me, and it preceded this whole era of point-of-care testing.
I see. Interesting. You know, one of the things I thought interesting, Tony, was that you didn't really demonstrate any change in the older patients who once underwent surgery or those who had lower risk operations, like the RACS 1 and 2 cases after implementation of this new approach. Do you think the reason for this is simply that, you know, these were easier operations and they had lower risk profile and patients just generally, you know, don't need as much support in the post-op period, or do you have any other explanation to explain why it is that it seemed like it really only had an important, powerful impact on the sickest and smallest patients?
Well, I think you know, everything that you said is, you know, kind of the way that I've looked at it. You know, it's like, you know, they're lower risk patients, they're less likely to die, and they don't require as much attention. But at the end of the day, and of course, you know, look, if you have a 1% mortality operation, it's going to take thousands and thousands of patients to show that there's a difference in mortality for something like that. But I think what I didn't do, and if I could be critical, is, you know, I looked at, you know, and maybe this is part of your clinician and you spend most of your time taking care of patients and, you know, you get some idea that you think is worthy of sharing and you want to get it out there. But you know, what I could measure, you know, in all of these patients was their, you know, mortality. And it was, you know, that's a yes or no kind of answer.
Sure.
It's easy for me to do the statistics, you know, and it's easy for people to understand the statistics. But what I didn't look at were other surrogates of, you know, how well a patient did, how many hours were on a ventilator. Did we change that? How long were they getting inotropes? You know, even things like length of stay I didn't go into. It was really, really too complicated. And we're talking about, you know, a program at the time that didn't have a cardiology fellowship where people could do stuff like that. We didn't have statisticians available to us. And if there's a real criticism, I could have looked at that data a lot more closely and come up with some stronger conclusions, because I think you would have seen, because it does make it, we measure lactate in everybody. And it's really, you know, like the key part of it is not the ones that you think the lactate is going to be elevated on. You know, you get a hyperplasia, you know the lactate's not going to be normal when they come out, you know, but it's the kid, you know, who had a tetralogy who should be fine. And all of a, you know, this one has a lactate of 3 and this one has a lactate of 3 and that one has a lactate of 7. You know, I wouldn't have predicted that. And those kids usually go home, you know, and they're supposed to go home. So I think we didn't look at enough stuff hard enough. And you know, I would say, you know, there are a couple of new things that are down the line that people are looking at, and I think this experiment that we did with, you know, goal-directed therapy to lactate could be repeated by people. And either confirm what we found or find it to be as good or superior to some of the newer things. Yes. It's like, or maybe better, you know, or maybe worse, you know.
Sure. Well, for those in the audience, it's actually quite late. I know I say this often when I'm doing these interviews, but I assure you this time I am truly telling you the truth. It is quite late. Tony, I'm going to end off with this final question, and you sort of were leading into it, actually. You know, you've clearly been a pioneer in the development of the use of algorithms and systems of care for the CICU, which today are pretty much established as the correct approach, but at the time you wrote this paper was quite a novel concept. I'm wondering if you might be able to share with us any other such protocols that your team in Nicklaus Children's use, and if you still today believe that the lactate is the right thing to be monitoring. Is there something else that you think might be superior? For example, those wonderful near-infrared spectrometry NIRS things that are destroying the skin integrity of all our patients, or perhaps
they say it doesn't do that, but you're absolutely right.
Or is there anything else that maybe you think should be used now in combination with lactate when you're thinking about patients?
So there, great question and great way to finish this. I mean, one of the things about when we wrote that paper, there were no papers on point of care testing in a cardiac ICU, pediatric cardiac ICU. There were zero. There were no papers on goal-directed therapy. Like if you go to PubMed and do goal-directed therapy pediatrics, like before 2000, there are no cardiac papers about that. Uh-huh. And the only place that people use lactate was to predict mortality. Mm-hmm. It's like, your lactate's elevated, you're probably going to die. It's like, and so all of those concepts are novel, but honestly, there hasn't been much, over the past 2 decades that's really looked at, that relationship between oxygen delivery and oxygen consumption. And it's everything, for our critically ill patients, it's everything. It's the difference between life and death. And what's been shown is that, look, we get this wrong a lot of the times. Like, for instance, there was this series of articles out of Toronto, about a decade ago by an investigator named Jay Lee, and for hypoglycs who come out of the OR, their cardiac output is actually quite good some of the time, mm-hmm. But their oxygen consumption is really quite elevated, and so it isn't even an oxygen delivery. It's like they got enough oxygen delivery, they're just consuming too much oxygen. And so, there's a lot there to explore. The NIRS, look, there I don't know, there was a cult of NIRS. It's kind of, I'm not saying it's fading away, but I think people are starting to understand that, the problem with the NIRS, and this was pointed out by the Boston guys, I think I've talked about it a little bit before, is that, what? If it's low, if your NIRS is low, you're in a low cardiac output state. There's no question about that. But you can be in a low cardiac output state, and it can be normal. And you can be, if that's the number that you're going with, it's like you're going to be completely misled. And if your lactate, is 2, you're going to do well, and your prognosis is good. But imagine if you had a test and it was, your pH was 7.2 and your test gave you 7.4 some of the time.
Right.
Like, you would make an error in judgment that would be enormous. And yet the NIRS has been proven to be erroneous by that amount, at some points in time. And, there's this kind of, you just measure the trend. Well, if it's telling you, if your NIRS says 70 and your true NIRS is 30, what does the trend mean? Like, I don't think, if it goes up a little bit or it comes down a little bit, what does it mean? I think that's useless, and I think people are using their cognitive biases to kind of make a case for that. And I think a lot of people now realize that the people in Boston, the people in Philadelphia, and we use it. Because if it's low and you weren't suspecting somebody to have a low NIRS, then it's helpful. It's just like you got to use it as one of your tools, and I think that's where lactate comes in. It's one of your tools for evaluating a patient, but it's an objective tool, and I will take an objective tool over subjective tool every single time. There are some, when you talk about, the analytics that are available, there's a company, Pediometry,
Sure.
that has partnered with a bunch of really superb children's hospitals, and there's some brilliant people that are behind this. I'm not sure that it's ready to go. They've developed this index. It's called the inadequate oxygen delivery index, and it's based on a whole bunch of parameters. The problem that I have is you can't really figure out how they're coming up with these numbers. And in this inadequate oxygen delivery index, which sounds fantastic, it's only been used to predict if someone has a low SVO2. And the way that they've confirmed that is using SVO2s, or mixed venous oxygen saturations, from a whole bunch of different places in patients because they needed enough data. So, it could be an SVC, it could be a right atrium, it could be a central venous line. It's those things can be off by so much from your true mixed venous oxygen saturation. So I don't think it's ready to go. And the software has been incredibly expensive. I was actually interested in this because it was right up my alley, that kind of,
Sure.
predictive analysis or analytics. But it was like six figures to get involved in this. And it's I don't know, the big places may have six figures to throw at this and say, hey, let's see what it's got. But, most programs don't have six figures to throw around every year. Yeah. It's not like, you buy it in and it's like you're good to go. So we'll see where that goes. But I still think that, we could do much better. We got to figure out, why our patients aren't, I always go back to my Philadelphia experience in hypoplastic left heart syndrome, and, it looked like, Norwood went to Philadelphia, and I don't know I forget what the number, 60% of his patients lived and 40% died after Norwood or stage 1 palliation. And then every decade it got better and better and better until we got to about 15% mortality. And we're kind of stuck there. And there's got to be things that we can do to help the surgeons out. Because I think surgically there's not going to be much more that they could do. They can't refine this operation much more than they're doing it now. And whether it's the traditional stage 1 or the Sano, they're all coming at the same. So we got to figure out a way to get, that 15%, which took a long time, but now is stalled, down to 5%. Something that we would really consider, and that's going to be on us. And I don't know where it's coming. I'm hoping for something. I'm hoping that some of these, predictive analytics, I hate to say artificial intelligence, because we're not nearly there yet. But there's got to be something else. But until then, the lactate, is simple. You get it with a blood gas. Doesn't require any more blood to be drawn from the patient. You get it frequently in the sick patients because they need blood gases frequently. And when it's elevated, your patient's in trouble. And and we know that if you can get it down fast enough, your patient's going to do better. Right. It's that's what this is all about.
Well, Tony, as always, remarkable clarity, just like back in 1990, when I was inspired to be a pediatric cardiologist, rounding with you in the ICU, I was thinking as I was walking through the hallway of Mount Sinai, how back in 1990, it was you, me, and Merrill Cohn. And I was thinking to myself, aside from me, there was some pretty big superstars on that team. Back then.
There were two superstars, but I wasn't included in that class.
So anyway, Tony, I really appreciate your sharing your great and deep knowledge of this topic with us all. We have a hypoplast going to the OR tomorrow. I'm going to be thinking of all these concepts when I go up and look at that patient tomorrow afternoon. Thank you so much for everything you've meant to me personally, but thank you most of all tonight for spending so much time with us and speaking about this very important and really exciting topic. Thank you so much, Tony.
Again, an honor to be asked to do this. I really appreciate the work you're putting in for this. Don't stop.
All right. Thanks a lot, Tony. Well, yet again, we've had a great opportunity to listen to one of the greats of postoperative care in Dr. Rossi, and his comments about how he came to use the lactate level in a goal-directed manner were of great interest. and his choice to go with that particular biomarker has clearly proven the test of time, as it is still one of the most important values that all of us use in common practice every day when caring for our congenital heart patients following open heart surgery. As he was uncommonly clear, as he always is, I think I won't comment any further other than to thank him once more for being our 200th episode guest and coming back on the podcast to share with us his knowledge. To conclude this replay of episode number 200 with Dr. Anthony Rossi, we end with one of the greatest baritones of all time, the amazing Robert Merrill, in a recording of the aria Di Provenza from Verdi's La Traviata, recorded over 70 years ago when Mr. Merrill was in the absolute prime of his career. New Yorkers of a certain age remember Mr. Merrill as the Yankees' good luck singer of the national anthem before important games. But long before that, he was well known in the opera world as one of the single greatest singers of the entire 20th century. And this role he's singing here of Giorgio Germont was one of his greatest. Thanks so much for joining this replay episode, and thanks once again to Dr. Rossi. I look forward to seeing you all next week for a brand new episode.
Ti trovo